We have a live presentation coming from Michigan. Dr. Fadi Saab, is he? All right. Fadi, thank you so much for giving us a wonderful presentation. Thank you.
Yeah, thank you for having us again. This is our second installment for the morning. I want to thank the organizers for inviting us, and congratulations on a great and successful meeting. So I'm going to go ahead and dive into our second case. This is a patient in her 60s. She presents to us with an ulcer involving the medial aspect of her heel and extending into the foot, placing her, in our opinion, at Rutherford Class 6. She has the typical risk factors with diabetes, hypertension, chronic kidney disease, and I wanted to show you some of the non-invasive studies with her ABIs of 0.7 and a TBI of 0.27. And we can go directly actually to our live images, guys, if you don't mind, the angiographic images. So with those cases, I typically, if there is tibial disease, I prefer to obtain antegrade access. So diagnostic angiogram, ultrasound guided, access of a common femoral artery, compressible. And these are the diagnostic images showing a disease involving the SFA and the popliteal segment. And this is our tibial image. And finally, our foot image. So with that, I'm going to stop and see what our panelists would like us to do. Move that out of the way. Hello, can you guys hear me? Pull the table towards you. Would I be able to get here?
Liz, what do you think?
Yeah.
So Fadi, would you be able to show us the more proximal images as well?
Proximal images of the tibials?
Of the SFA pop as well.
Can you go back to the SFA?
Going back right now, that's it.
Yeah.
Then do you have the one for the popped tibial? So obviously, when you're trying to think about a heel wound and you're trying to get a heel wound to heal, you're concerned about kind of the wound angiosome that you're trying to perfuse, and so it looks like there's a
Repeat
degree
sedation,
of
guys.
above the knee and below the knee disease, and obviously, if ideally you can get direct flow to the posterior tibial artery to try to really increase that perfusion head to the heel would be ideal. So it looks like trying to cross that. Ideally, I'd probably try to see if I can get some PT direct flow to the heel, but also treat that inflow lesion just to kind of start.
That's a great point, Liz. Our interventional ultrasonographer, Kaylin, is by the foot right now. So I want her to show you our posterior tibial artery. So she's scanning right now from the foot toward the knee. And go ahead, Kaylin. So she's following, going up toward the knee, and then this happens. Mm-hmm. Any thoughts? She's going back and forth to, this is for our fellows in the audience who are watching. It's a unique situation here. And where the arrow is a vein. So we have an anomalous supply to the heel section with what appears to be the perineal supplying the common plantar artery. We don't have a native posterior tibial artery, despite the angiogram appearing to have a posterior tibial artery. And that area in it by itself looks like it's fibrotic and occluded, with the common plantar also being occluded. So options of therapy here are, I have a few in mind, but I'm going to start by obtaining the DP access. I want our fellows to watch. the access under ultrasound. All of our access points are under ultrasound. You can see the subcutaneous edema, and you can see the veins being compressed. Can you compress them? So that's the sign that you can differentiate between the artery and the vein. In some vessels, and here you can see some calcium on the posterior wall of the dorsalis pedis artery. It's very superficial. And we're going to try to give some lidocaine to some patients feel it, some people don't. Honey, you going to feel a poke?
Fadi, you have some high-priced help in the sense that you have a vascular technologist in the room with you. Many people don't have that. Can you talk through how to incorporate ultrasound guidance in your procedures, both in terms of access? I think most interventionalists can do the ultrasound for access themselves, but how about PAT studies and that sort of thing? Is that something you think we can do as interventionalists without having the extra technologists in the room?
You touched on one of the lectures that I give is about the role of extravascular ultrasound, or EVAS, in the treatment of PAD and CLI patients. And I think obtaining access is just the introduction to the use of ultrasound. Ultrasound is important in tackling CTOs, monitoring CTOs, decreasing radiation, decreasing contrast volume, and ultimately making sure that we have hemostasis and choosing closure devices. Now, the question becomes, well, if you don't have an interventional ultrasonographer with you, how can you utilize those services? Sometimes we've had people that will train their techs to perform these procedures, especially for scanning for complications such as perforations and hematomas. You know, that's a valid approach. I've told some people also, if they work in a hospital environment, right now we're working in our ambulatory surgical center, but if you work in a hospital environment, you can work with your imaging department to develop a protocol where ultrasonographers can come assist you in obtaining pedal access, for example, and leave the case. And we successfully managed to do that in our hospital environment. And the argument to the administration, to be honest with you, is if you're not able to obtain pedal access, you're not able to perform the procedure. So obviously, I know finances are always part of what administration and physicians think about. So, unless you're successful in the procedure, number one, you're not going to be able to help the patient. You're going to expose them to another procedure. But number two, it's not going to be financially conducive to the institution. So that's how we got some purchase from our institution to support this endeavor. Here comes a poke, dear. So I'm accessing close to the probe under ultrasound. And what I'm going to do is, there's no benefit to using ultrasound if I cannot see the needle. So I'm seeing the needle, I'm coming on top of the vessel. Without me talking to Caitlin, our interventional ultrasonographer, she moves away or she comes closer to me. So I'm on top of the vessel, and I'm going to apply sustained pressure, and she's already pointing to me that I'm moving to the left. So I'm going to adjust my vector a little bit, and then, again, apply pressure forward. She's going to scan back and forth to see if I'm in the wall or I'm through the vessel. Looks like maybe I'm in the wall. Yeah. So already the vessel escaped from me, so I'm going to pull back again and redirect toward the vessel. Yeah. And we're in. So what we're going to do next is, with the hockey stick probe, she's going to switch from short axis view to long axis view. And under ultrasound guidance, and this is something that, when we train our fellows, we say, there should be no resistance as you're advancing this wire. So I'm meeting resistance, so I'm tugging on the needle. I'm not pulling the needle, I call it tugging on the needle, and I'm probing with my wire. Tugging, and there you go. You show it, Caitlin, better.
Beautiful. Yeah.
So that's the wire in the vessel there. So I'm going to advance it, and Caitlin's going to try to follow it under ultrasound guidance. One thing she's checking also if I'm subintimal, because sometimes you can be subintimal with that wire, and that wire can go smoothly in a retrograde fashion. So she's following it. I'm not looking under fluoro. I'm not looking under with contrast. So what we're going to do next is we're going to place our 2.9 French sheath.
So Fadi, that was a great demonstration. It's Lawrence Garcia, but I've always found it hard to have two hands in there besides mine with ultrasound and support, because I can always change the angle. But that was really remarkable tandem work that obviously demonstrates that in your lab, your ultrasound sonographer knows what you're doing with your needle, and that's really the interplay between operator and sonographer, very well demonstrated.
Thank you, Mark. But, and you know, one thing I always get asked, like, how long does it take? Because you got to understand that our ultrasonographers, they're trained the traditional way. They're trained to scan. So it's upon the physician to train them of how to change their modality. It takes about in my opinion, takes about 6 months to train them and to make them comfortable with what we're trying to do. And obviously you need someone that's passionate about this and enjoys this type of work. And by the way, they can be your scrub person in the procedure. They can support you in the procedure. So you don't have to have another scrub tech with you. So just food for thought.
I think what it also shows is that there's multiple ways to do this type of procedure. In the previous case, it was done fluoroscopically with X-ray guidance. Here it's being done ultrasonography with ultrasound. So there's definitely multiple ways to kind of do this kind of thing.
Wait, Miguel got pedal access with fluoroscopy?
He accessed the distal popliteal artery using fluoroscopy.
All right, so I got to shame him on that after the procedure.
That's how you get a fistula.
We want our fellows to learn ultrasound. Just joking, guys. So we're gonna show you what we have integrated. So we already have our wire that cross back. So I want to show you this last image. Andrew, do you mind coming?
I'm coming right here. Yeah.
Do you mind showing us that selective image that we had?
This one.
Yeah. So, you know, there's different advantages in my mind for pedal access in this case here. But I want to play this image because it shows the advantage of pedal access. If you guys would notice, there's almost like a nub. And to be honest with you, I thought that this is the takeoff of the AT. Do you guys agree?
That's what it looks like.
Yeah, but actually the AT is the vessel below it. So let me show you. So I'm gonna
Fadi, did you
magnify a
try
little
to
bit.
cross that from above?
No, I did not. I did not want to mess up that vessel or mess around with any of those collaterals. So, in my opinion, retrograde wire approach is safer in those patients because retrograde dissection. And I think if you saw my last case, you saw what antegrade dissection did with a 4mm vessel. So.
Let me ask the panel. Who would have gone pedal here, or who would have at least tried from above?
I mean, I think it's always
open the Viper wire, please.
beneficial
Open
to try from above. I don't disagree with the idea that when you try from above, you get into subintimal dissections. And certainly when you come up retrograde, sometimes it's remarkable how easy it is to cross. But you can have the same problems from below, too. And so I tend to go from above, go antegrade from above, trying to cross in almost all cases first.
You wanna...
Like in the last case where Miguel kind of stopped and didn't push forward because he didn't want to dissect, I probably wouldn't have done that. I would have tried from above. But what I have moved to now is I don't spend nearly as much time coming from above as I used to, because I think that once you start struggling from above, if it's not going easily and smoothly, if you feel like you're in deep subintimal planes, it's almost always better to just abort that and go from below.
I think it really depends on the quality of the dorsalis pedis. If that's a very calcified dorsalis pedis, then certainly I'm going to try not to stick it because it could be problems potentially. So generally speaking, I think a couple of minutes from the top and know your limits. And if it's not, then just hit the bottom.
See, I'm just the dumb cardiologist, so I always say that smarter people would have quit
So
a
the
lot
Viper
sooner
wire, give it to
than I
Caitlin,
would
please.
have. So I usually try a little bit longer than I should. That's the problem.
I guess knowing where the limits are, I mean, respecting the
180?
collaterals,
give it to Caitlin,
not
or
doing
Ruth.
subintimal unless, I mean, you'd rather do a retrograde than to dissect like 20 centimeters or subintimal, right? I mean,
you need a cheater?
That's the key, because I think Brian just said it. You know, you
Oh,
can
that's
come
right,
from
okay.
above, get dissected, but you can come from
forgetting you go in the
reverse
back
and
of the
still
wire,
get
that's smart.
dissected. And sometimes you don't see that, or you can't feel that as easily when you're going retrograde. But I think they both have value, and you just have to know what's happening with your wire by all
are
means.
you guys normally sheathless?
Makes
or-
sense. Too.
Sheathless, yeah.
Yeah.
Just do a support catheter. Sure.
Would anybody go pedal only in this situation?
I haven't. I like dual access. I like working from above eventually,
And
and I
take
think
the
that's what he's
catheter.
trying to get his catheter in that, get his wire through that catheter.
Yeah, I agree with that. I think it's much safer when you have access from above. You can image better.
Can you go with
And then
IVUS
also
next?
in terms of hemostasis, it can also be very helpful.
I don't want to
Give
go
a
on a big
cast.
soapbox against pedal only, but I do think that if you're doing pedal access, you're doing it for CLTI. If you're doing it for CLTI, your final image should be one where you shoot from the groin, from the common femoral, show inline flow to the wound itself. You can't do that if you do pedal only. And so I think it violates a basic principle of
Couldn't agree with you more.
revascularization.
Couldn't
So
agree with you more.
I'm not saying there aren't times where it's appropriate to do it, but I think that as a routine, it doesn't make as much sense. Now, you could argue that if you have you're skilled with duplex ultrasonography, you have your interventional tech, your completion imaging could be a duplex ultrasound down to the wound essentially. But I just don't buy that, and in general, I don't buy that. I don't think most people are actually doing it.
So actually, I mean, we have a couple of good case series on the TAMI procedure, which is pedal-based revascularization, and at least in those case series, our outcomes have been very favorable with pedal-based revascularization. But I think a couple of points that were made by the panel in terms of making sure that you have a relatively healthy plantar circulation. Can you ring down, please? Is important. And having having ultrasound right then and there is also important because you want to make sure that when you remove your sheath, you have patent hemostasis. Start recording, please.
Eddie, we're going to come back to
so-
you in a
so-
minute. We're going to let you get that wire through and through. Final slide regarding that algorithm was very, very helpful. Let's go back to the case. Let's go back to Michigan. Fadi, I saw that you evaluated everything using IVUS. It looked like you were sizing the lesion with IVUS. Is that your normal routine? How helpful was that to you? That's my first question. My second question is, it seemed like you were using orbital atherectomy, CSI, and you treated the SFA as well as the tibial. Was that largely based on the angiogram that you saw or the IVUS image?
Yeah, they're both good questions. So if you can see the IVUS run, because I essentially use IVUS 100% of the time if I can. Again, I think the data is pretty compelling to the use in terms of variety of things, sizing, position, nature of the atheroma, and so on and so forth. So here you can see actually areas of positive, well, I don't know about if it's remodeling, we're guessing, but you can see the different sizes of the vessel even within the SFA itself. So it goes from 6 millimeters to go to 5 millimeters. But I want to point your attention to this area right here. So you guys notice there is an area, this is in the AT. So you can see that around the vessel there, it looks like either an old hematoma or a thrombosed aneurysm. Not really sure what it is. A patient had prior interventions in the past, and that could be possibly the case. But I think this was so helpful because I avoided doing atherectomy, obviously, in this segment here. I think any mechanical disruption here could potentially be catastrophic for the patient. I use orbital atherectomy because the nature of the atheroma here appeared to be mixed, especially with tibial SFA popliteal disease. This typical CLI patient has multi-vessel, multi-level disease. We want to establish inline blood flow all the way to the foot and possibly try to recreate the pedal loop or definitely assess the pedal loop in a better way toward the end. I usually size my atherectomy device to the tibial vessel. You can choose to open 2 devices, but knowing the mechanism of action with orbital atherectomy, you can achieve what you need based on velocity, and the repeat numbers depends on your patients. Go down, please.
And
So we performed orbital atherectomy in the SFA and the popliteal on high about 4 or 5 times. And I chose a 5.0 balloon. I sized the balloon to the popliteal segment. I might go back with a 6.0 in the SFA. And then I chose, go ahead.
up to 2?
4.
2,
And I chose a 3.5 millimeter balloon to the proximal to mid-tibial
I'm at 4.
to treat it after atherectomy there. And I'll be curious what the panelists think about treating the AT area. Would you, what would you do with that? 6.
And 6. Up at 6. Clock's on.
We're not bleeding anymore.
Are you referring to the potential hematoma or a prior aneurysm? Is that what you're concerned about with the AT?
Yeah, yeah.
Can we show it angiographically?
I mean, I don't see anything on that imaging that would suggest that it should be treated any other way. Whatever it was, if it was from a prior intervention, it seems like that's a resolved problem, and I probably would just it wouldn't affect my decision on how to treat that. Do you have specific concerns about certain modalities being more or less safe?
Well, I was just like, if this is thrombotic and I use I guess a mechanical device, in my mind I divide them that way, so it might be disruptive. This is probably a fragile area here. It measures almost 6 millimeters in the proximal anterior tibial artery, so definitely not normal. I'm going to balloon it and we'll see how it looks.
Patty, we're going to let
and
you
you also-
finish your intervention. We'll come back to you in a few minutes. We're going to get our next. Let's go back to Michigan for a few minutes, and then we'll finish up with Dr. Robertis. How's it going over there, Fadi?
Yeah, hi. So we're going to show you the results of balloon angioplasty. Andrew, do you mind showing them?
Sure.
So we treated the proximal SFA with 6.0 balloon, the popliteal with a 5.0 balloon, and we treated the AT with a 3.5 millimeter balloon. And these are the results. Go back, Andrew, I'm sorry. Show them the pop. Yeah, go back more. Okay, go forward. I want to show you the AT results. Okay, then go forward. Looks very reasonable. Go forward. So now, remember, this patient has a heel ulcer, anomalous, occluded common plantar PT from the perineal. So the goal is to try to navigate to the pedal loop. Go forward. Pedal loop, and this is we're using a 2.5 millimeter balloon. This is a Xi'an black wire. Another good wire. Next one. Another good wire would be a regalia wire. You want something soft, atraumatic to navigate these difficult or tortuous vessels, not necessarily difficult.
I have a question for you. Seemed like you had a pretty reasonable result.
Hold the wire.
Down to the foot. When do you decide to go after the, pedal loop? When do you start doing this kind of work?
Really depends on the location of the ulcer. So if I'm able, and there's a lot of work that's been done in terms of pedal loop reconstruction, and the reality is it's not all or nothing rule. It's basically essentially if you're able to achieve a complete pedal loop, your healing rates, depending on which trial you look at, not yet. Depending on which trial you look at, is 70, 80%. Now, keep in mind that these are all registries and not randomized trials per se. Indirect or incomplete pedal loop is kind of in line with the indirect angiosome process, kind of estimated at around 60 to 65. So I'm trying here to basically go all the way to where the heel is to complete the pedal loop. And take me off-road, Matt, please.
You're off.
So I have you can use a support catheter I moved toward using low-profile balloons because kind of can do hemostasis of the access site at the same time. If I'm in the right location here, I would suspect for this wire to go toward the perineal, possibly. So we'll see. Gonna advance our balloon.
Fadi, this is PK. Just a quick question. I'm just wondering, I mean, you're using the loop technique as you're dissecting. Just for the audience, are you worried about disrupting any of the circulation into the area you're trying to perfuse by maybe closing the collaterals?
Hey, PK, great to hear your voice. That's a great question. What I'm doing right now is retrograde dissection. Now, I'm not saying it's not, you know, it's always safe or benign, but it's still retrograde dissection. And any blood flow we're going to go after is going to be antegrade blood flow. Or any blood flow coming to the area is going to be antegrade blood flow. So in theory, I'm not disrupting any of those antegrade vessels. Now, one thing I can do also here is I can, Caitlin, our eagle eyes here, ultrasonographer is going to be looking with ultrasound to tell me, like, okay, you're subintimal here or you're true lumen here. Quite frankly, if I can get just to that ankle area there, and I'm in the true lumen, where I can get the calcaneal branches, then I think I've achieved my goal for the day. I don't want to necessarily connect with the perineal artery, so we're looking with ultrasound. Maybe it's hard when the vessels are very small, but at least if I get to the, looks like reasonable there. That looks like in the vessel there. What I'm looking at, PK, is the circle, the vessel, which is the circle. The bright dot is essentially the wire. And this is the hockey stick probe. You really need a high-frequency probe to be able to discern the difference between the artery and the vein. So I think that's reasonable there. I'm comfortable performing balloon angioplasty in that segment there. Let's go.
Just a quick question. Do you ever give injection through your retrograde catheter to see, or you don't in case you're too subadventitial?
So I am actually, sorry, Keelan. Where I am right now, the tip of my balloon is an occlusion. So if I inject, I know for a fact, let's go up to 4. I know for a fact I'm going to see like not extravasation, but you know when you see the kind of where you're in a CTO per se. So what I'm going to do, I'm going to balloon this, and then I'm going to pull my balloon to the proximal third of what I believe is the lateral plantar artery that's occluded. And then I'm going to take an injection from there, and if I can see calcaneal branches, then I'll be satisfied with this result. If I don't, then we've achieved an incomplete pedal loop, and you know, we have to be mindful of the lower healing rates for a patient with this problem.
It would be interesting at this point, prior to attacking the foot, if we really use the acceleration times to see pre and post, because if you have an improvement, maybe there's a threshold to come, because you could always come back, right? I mean, ultimately, you have an improvement, you walk away. If it doesn't heal, maybe it's not as much as you need, but why venture on Saudi? Why take that chance?
I'm sorry, I did not hear the question very well. Can you repeat it again, please?
Why not with one form of assessment, either an AT time with everything you've done short of the pedal loop, and if it's improved, walk away because you can always come back? Well, why target it from the beginning?
I think it's the same argument can be applied to treating the SFA and leaving the popliteal occluded, or treating the popliteal and leaving the tibials occluded. You're increasing the perfusion pressure. Why don't you see if the patient improves? And you know, the data is clear. You know, if you have a complete pedal loop in a patient with a wound, you have a better healing rate. That does not mean that if you don't do it, the patient does not heal, but it's a matter of what are you willing to do, what are the expertise of a center, and you know, your comfort level as an operator in terms of how to address these. I agree with you. I mean, obviously, you know, you don't want to treat these vessels for, you know, obviously you don't treat them for patients with rest pain, for example, or in my opinion, my humble opinion. But for patients with this type of illness and whatever ulcer is, I think this would be, you want to achieve inline blood flow to where the wound is.
Fadi, it's Liz. You've done a great job so far. I think the results you've gotten through the AT are remarkable. Quick question for you. AC, obviously with the point of doing the pedal loop is to get more perfusion to the heel. You have what looks like to be a flow limiting lesion in the TP trunk, and you have some good flow. What you started with, if I remember correctly from the initial angio, was what was feeding the foot was the perineal. Is there a reason why you chose to come through the pedal loop to get to the heel as opposed to optimizing the flow through the perineal to see if you can get some more collaterals from the perineal itself?
You know, I think that's a great point, Liz, but you know, you said it, collaterals from the perineal, so it's not inline direct blood flow. My hope or my goal was to achieve inline blood flow directly to the segment. So that's why I chose the ATDP approach. But you know, I don't think it's unreasonable what you're suggesting either. I mean, that's very reasonable too. Take us. Picture here. So I just removed my wire. I'm going to take a picture here just to see what we're dealing with. So this is disappointing because I was hoping to see some calcaneal branches, and I am not. So let's see. One option, and I'm not going to do that here today, but just for the sake of discussion, one option is always actually to go from the distal perineal. That will be, in my opinion, a more aggressive approach, to try to connect to the lateral plantar artery. It's interesting, I see competitive flow. Do you guys see that? You guys see how I had to like force inject? I wonder, so next thing I'm gonna do is I'm gonna ask Caitlin to look with ultrasound at that common plantar area that was occluded. I'm gonna give some nitro. 100, yeah. I'm going to see if she sees anything.
Fadi, as you do the ultrasound in SpeakAid, just a question. How did you size that balloon? Did you IVUS it, or do you have an algorithm for sizing balloons in the loop? Because it's obviously takes a lot of experience.
Yeah, that's a great question, PK. So the dorsalis pedis artery here was at least 2.5 millimeter. So I usually would go down 0.5 millimeter when it comes. I will size the balloon based on the arcuate, on the arcuate artery size. I think that if that common plantar or lateral plantar was open, it would be a 2.5 millimeter vessel. But since I'm going to balloon across the arcuate artery, I'm going to size my balloon to that, which I usually take 0.5 millimeter less than what I use for the DP or the lateral plantar. So I don't know if you can see the, so I don't know if you can see the image, but we having maybe monophasic flow in the lateral plantar, which is not necessarily bad. So I'm going to stop here. I'm going to take another picture to show you the foot. Yeah, there's collaterals there. And we'll sign off to let you guys carry on with your next presentations.
So as we depart this one case, the one thing I'd defer to Art Lee, but the pedal arch is one of those things where I think we really need devices that are specific for it. I always get nervous about muckering up the arch. And so I think we need a balloon that, and maybe industry can, this is free, you know, we give away our IP for free, but here's the problem. I think what we need is we need a balloon that truly is a dog bone balloon. We need something that doesn't dilate the arch so we don't F it up. and dilates on either side of that. And that would be something that would maintain the arch so we don't have a dissection there. Because that macerated location is the one thing that's going to salvage the foot in the future. And if he has to rework on it, it's the thing that won't be
You
back.
get flow from the
So-
medial malleolar branch. You know, I could not agree more with your comment, Dr. Garcia. Just for our fellows, the area that you see in the mid-DP, that's our access point. It's usually spasmodic, and through experience, you leave them alone, and they usually recover. I want to point out that medial malleolar branch is kind of supplying the area, and it's actually providing collaterals to the distal medial plantar artery. And the lateral plantar artery now is filling directly also from the dorsalis pedis artery. So this is a patient that we're going to see. One thing also that's lacking, I would like to add, is on the table perfusion assessment. This is also an area that's, in my opinion, that's lacking for a lot of those patients. I know a lot of companies are working on that. You know, Philips has the perfusion software, and there's other imaging modalities. But you know, we need technology like right here on the table, where you know it's not a matter of my opinion or someone else's opinion. We need objective parameters to help us decide when is what we did is enough. So I'm going to show you one final image of the AT, and we'll sign off.
Fadi, thank you so much for a very complex case, very informative, and it looks like a good result. Thank you again.
Thank you, guys. Thank you for the invitation, and best of luck.